Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This is one of the another topic in neurology, that is ptosis, or we call drooping of the eyelid. Very frequently asked in your short note or maybe also in your oral exam, and you will see in your everyday practice quite common. It can be benign to an extreme we call pathological. So very clearly you can see ptosis. This is unilateral ptosis, very clear. Any person who comes to your way, you must investigate properly. It can be benign to an extreme, a pathological, which can be because of the damage to the nervous system. So ptosis is a word which is derived from ptosis in a Greek means fall. So it is a drooping or a falling of a upper or a lower eyelid. But by and large, it is mainly of the upper eyelid. Now this particular drooping is abnormal drooping of the upper eyelid. We call that as a ptosis. Normally upper eyelid will cover only 1/6 of a cornea, that is only 2 millimeter. Therefore if it covers more than 2 millimeter of cornea, we'll label that as a ptosis. And depending upon how much area it covers, we put them into mild, moderate and severe. We'll be coming across that. You can see here clearly bilateral ptosis. This is only one eye is being affected. Here again one eye is affected. And you can see when the person opens the mouth, that eyelid is lifted up. This is typical in Marcus-Gunn syndrome. We'll be talking about the different terminology which will be utilized depending upon the etiology: mechanical, neurogenic, muscular, aponeurotic, traumatic and pseudotosis. We'll be mentioning all these different words. Another way in etiology only congenital and acquired. And among acquired, it can be all this: mechanical, neurogenic, neuromuscular junction, aponeurotic, traumatic and pseudo. So you divide into true and pseudo, and then in true this will be the 4. Sorry, this will be the 5. Mechanical, neurogenic, neuromuscular junction, aponeurotic and traumatic. In some of the condition it is unilateral. Say in mechanical, good number of time it is unilateral. In neurogenic also good number of time unilateral. But in case of a myoneural junction, particularly myasthenia gravis, it may be unilateral or it may be bilateral. Now in a neurogenic, particularly say in a Horner syndrome, it is partial. While in case of a third cranial nerve palsy, it will be almost complete ptosis. So depending upon that, you use a word. So unilateral is very common in Horner's and occasionally in third cranial nerve palsy. But unilateral complete, third cranial nerve palsy. Unilateral partial, Horner syndrome. And bilateral will be classical in case of a myopathy and myasthenia gravis. It can be temporary, say like in a case of a mechanical or myogenic, and it recovers on its own, while permanent is very frequently in a irreversible damage to the either third cranial nerve or maybe in a Horner's, which we call as a neurogenic and permanent. And depending upon the severity, we divide them into mild, moderate and severe. So now you can see this is mechanical. This may be neurogenic. This has to be more likely to be myasthenia gravis. This is unilateral. You can see this is because of the mechanical. This is mechanical. Because of some pathology in the upper eyelid, because of the heaviness, you get ptosis that will recover as soon as you treat the condition. And this is very peculiar. When person opens the mouth or person moves the jaw, the ptosis will be corrected. That is very commonly in a Marcus gun. Congenital among acquired, neurogenic, myogenic, aponeurotic and mechanical. And pseudotosis. So neurogenic will be third cranial nerve palsy and Horner's, and Marcus gun jaw winking syndrome. That will be neurogenic. While myogenic, two classical example, myasthenia gravis and ocular myopathy. Also in case of a myotonic dystrophy and blepharophimosis syndrome. Aponeurotic is another, and another is mechanical. We use a common word unilateral, bilateral, complete, incomplete. Now combining together partial and total. Total unilateral is classical in case of a third cranial nerve palsy, and partial unilateral is there in a case of a Horner syndrome. Mild to moderate unilateral more common in case of Horner's or partial third cranial nerve palsy, and mild to moderate bilateral is classical in myasthenia gravis, muscular dystrophy and ocular myopathy. So this will be classical examples. If there is a 2 millimeter drop, it is called mild. If it is a 3 millimeter, moderate, and more than 4 or more, severe ptosis. So we will have to measure from the center of the cornea how much is the drop. So depending upon that, you label. So distance between the upper eyelid margin and the corneal light reflex, that is MRD. So marginal reflex distance. Marginal reflex distance, MRD, is a distance from the margin of upper eyelid to the center part of the cornea. Corneal light reflex. That is, you measure, you call as a 2 millimeter drop, mild, 3 millimeter drop, moderate, 4 millimeter severe, or more than 4. So that will be severe. In severe, you will have disturbances in vision. There is another way, that how much is the upper eyelid excursion. So in a normal, it is 15 millimeter. 8 millimeter we call good. If it is 5 to 7, it is fair, and 4 millimeter or less we call as a poor. This is called Buck's method, but this is better. Marginal reflex distance is better. Etiology we have already mentioned. We divide into congenital and acquired. We put them into true and pseudo. We divide them into unilateral, bilateral, partial or complete. And then we put them into this upper 5, mechanical, neurogenic, muscular, aponeurotic and traumatic. This 5 will be very classical in case of a congenital or acquired. While pseudotosis is pseudotosis, while true ptosis will be any one of this: mechanical, neurogenic, muscular, aponeurotic or traumatic. And then depending upon the involvement, unilateral or bilateral, partial or complete. So we already mentioned unilateral is classical in case of Horner's and third cranial nerve palsy. Bilateral is very commonly in myasthenia gravis and myopathy. Temporary is very common in mechanical and myogenic, and permanent is classical in case of a neurogenic. And severity wise, mild, moderate and severe. Unilateral and bilateral we have already mentioned. Partial will be more common in Horner's. Complete will be more common in case of a third cranial nerve palsy. So this will be roughly the etiology. So depending upon the amount of ptosis, 2 millimeter mild, 3 millimeter moderate, and 4 millimeter or more than that severe. And we already mentioned acquired can be neurogenic, myogenic, aponeurotic, mechanical, or neurotoxic, and pseudotosis. Among congenital, one of the classical example is Marcus Gunn jaw winking ptosis, or it is also called as a congenital synkinetic ptosis. So whenever jaw is moved, the upper eyelid will move and ptosis will be reduced. Blepharospasmic syndrome is one variety and simple congenital ptosis is another. Most common is Marcus Gunn. There is also something called as the inverse Marcus Gunn phenomena, means synkinesis between cranial nerve 5 and levator, more rarely because of the causes the ptosis on the mouth opening. Rarely causes ptosis on mouth opening. There are other syndromes like Lambert-Eaton syndrome, Marin-Ament syndrome, eyelid myotonia, blepharospasm, then apraxia, Rosenbach sign, etc. We are not discussing in detail. Among acquired, neurogenic, myogenic, aponeurotic, mechanical, traumatic, and neurotoxic. We'll be going through that. As far as pathophysiology is concerned, we can mention that in a mechanical, it is because of the heaviness in the upper eyelid, because of infection or a tumor, etc., or a swelling. The upper eyelid will become heavy and it will droop down. In a neurogenic, because there are two muscles which is helping the upper eyelid to be lifted up. One is levator palpebrae superioris, which is supplied by third cranial nerve, while MULLER muscle, which helps levator palpebrae superioris to lift up, and that is supplied by sympathetic supply. So whenever sympathetic supply is affected, MULLER muscle is affected, which will produce partial ptosis, and that is very classical in case of a Horner syndrome. And along with that, in Horner's, you will have a meiosis, because dilator fibers are affected. So you will have a meiosis, partial ptosis, and hydrosis will be very, very typical. So ptosis, anhydrosis, and meiosis. These are very, very typical in case of a Horner syndrome. As well as you will have an absence of ciliospinal reflex, etc. I have already uploaded a video on Horner syndrome. In neurogenic, another thing is because of a third cranial nerve palsy. When you get a unilateral third cranial nerve palsy on the side of the damage, you will have a almost complete ptosis. Eye will be pushed down and out. Pupil will be dilated and fixed, not reacting to light. This will be classical thing, will be seen in a third cranial nerve palsy, and the muscle which will be affected in that will be superior rectus, inferior rectus, medial rectus, and inferior oblique. Hence, the eyeball will be shifted down and out, and person will have a diplopia while looking in and up. Diplopia will be more in that particular field. So that will be very peculiar in case of a third cranial nerve palsy. As far as a myoneural junction is concerned, two classical examples, ocular myopathy, other varieties of myopathy, and in case of myoneural junction involvement in case of myasthenia gravis. In a case of myasthenia gravis, it will be usually bilateral, partial ptosis, intermittent, it will be exaggerated by exertion or by constant watching, reading, etc. So that will be peculiar in myoneural junction. Traumatic will be because of the damage to the upper eyelid or to the nerve supply, will be coming across that. So because of ptosis, one, cosmetic effect, and when it is severe, it will produce disturbances in vision. And because of that, person will be constantly trying to elevate the upper eyelid, and he will adjust partially by rotating the head, that is upward. We already mentioned the symptoms in case of a Horner syndrome in third cranial nerve palsy. So to reduce the diplopia, person will have a peculiar posture. You can see here, this is because of the upper eyelid being involved. Here you can see there is an unilateral ptosis. Again, person will try to adjust by shifting the head. So visual problem will be there. Eyebrow will be elevated. Cosmetic purpose wise, it will be looking odd. And forehead furrowing will be seen. And you will have a head tilting back. We already mentioned it can be unilateral or bilateral. It may be complete or partial. And it may be mild, moderate or severe. We have already mentioned this particular and we have discussed this particular. Mild, moderate and severe, we already 2 millimeter, mild, 3 millimeter, moderate and more than 4 or more than 4 severe. Now we are going through some of the conditions. Simple congenital ptosis is usually unilateral. Skin eyelid crease is absent and the ptosis lid is higher in a down gaze position. That will be peculiar in case of a simple congenital ptosis. And levator function, levator palpebrae superioris function is reduced. So this is typical in case of a simple congenital ptosis. In a blepharophimosis syndrome, there is a congenital ptosis, blepharophimosis, and telecanthus, or it is also called as epicanthus inversus. So it is because of this peculiar phenomena, blepharophimosis syndrome will be there. In Marcus gun, it is peculiar that 5% of the all causes of congenital ptosis is Marcus gun, and there will be retraction or wink of a ptosis lid in conjunction with the stimulation of ipsilateral pterygoid muscles. So whenever a person opens the mouth or there is a movement of the jaw, ptosis will improve. So there is a retraction of a ptosis eye with a jaw movement. It is classical in case of a Marcus gun jaw winking ptosis. Typical. You can see here ptosis. He opens the mouth, ptosis becomes less. Again here, you can see ptosis become less. Opening the mouth, ptosis becomes less. It is also called trigemino-oculomotor synkinesis. So whenever you use a trigeminal nerve, simultaneously there is an uplift of the ptosis eye. So that is very characteristic in case of a Marcus gun jaw winking phenomena, or you also call as a trigemino-oculomotor synkinesis. Neurogenic ptosis, third cranial nerve palsy, Horner syndrome, very rare in case of ophthalmoplegic migraine and in case of multiple sclerosis. More common with third cranial nerve palsy and Horner syndrome. So this is Horner syndrome. You will have oculosympathetic palsy, usually unilateral. There will be mild ptosis and meiosis. You can see here there is a mild meiosis and mild ptosis. Compared to this, you can see there is a slight ptosis, and it is because of the paralysis of Muller muscle. So in a neurogenic third cranial nerve palsy, and we have already mentioned, it will be down and out, dilated pupil, and almost complete ptosis. So that will be in a third cranial nerve palsy, lower motor neuron. So third cranial nerve palsy. which will be neurogenic, and person will find difficulty in adduction, upward movement and inward movement. Another very myogenic variety, classical example myasthenia gravis. It will be worst by constantly using, like reading, watching, etc. And person may complain of diplopia because of imbalance between different muscles. And you can have also in case of ocular myopathy and myotonic dystrophy. This particular can also be produced because of ocular thyropathy, particularly in case of a Graves' disease. So ocular myasthenia gravis will involve and will produce maybe bilateral, maybe unilateral, and it is usually intermittent. Aponeurotic is due to dehiscence, disinsertion or stretching of the levator aponeurosis. That's why it is called aponeurotic. So there is a little stretching of the levator aponeurosis, very commonly seen in senile person, maybe occasionally because of traumatic or post-operative, and most common in senile person. So that is described as a aponeurotic. Mechanical is mainly because of tumor, lid edema, sty, etc. Trachoma, those particular conditions. Tumor or dermatochalasia, lid edema, or even what we call as vascular malformation, sty, all those conditions. Pseudotosis is very frequently because of the skin fold. Skin fold. That is because of skin fold. So that produces pseudotosis. So while examining for the ptosis, you will have to do the inspection of eyebrow, forehead, eyelids, lacrimal apparatus, etc. Look at the head posture. Look at the ocular motility to rule out third cranial palsy. Check visual acuity and do not forget to examine the pupil because that will be affected in Horner's as well as in case of a third cranial palsy. While in case of myasthenia gravis, aponeurotic, mechanical, pupillary, size and reflex will be normal. First, you have to rule out pseudotosis from ptosis, and then we measure the marginal reflex index and how severe it is, unilateral, bilateral, partial, complete, etc. should be examined, and then we must examine the function of levator palpebrae superioris and extraocular muscle. So marginal reflex distance, vertical fissure heights, etc. should be examined to make out mild, moderate and severe. Investigations is mainly done to rule out myasthenia gravis, Horner syndrome and third cranial palsy. And there are some different tests like phenylephrine test, ICE test. ICE test is mainly for myasthenia gravis, neurological examination and tensilon test. So we try to differentiate congenital and acquired, pseudo, mechanical, etc. And we want to find out whether it is third cranial nerve, myoneural junction or because of Horner syndrome. So ICE test, if it improves, more in favor of myasthenia. So tensilon test, EMG, ECG, thyroid function test will be helpful to find out the thyrotoxicosis producing ophthalmopathy. EMG will be useful again in case of myasthenia gravis. Tensilon test will be also useful to rule out myasthenia gravis. As far as treatment part is concerned, it will depend upon the basic etiology. In case of mechanical, surgical intervention may be helpful. In case of myasthenia gravis, drugs will be helpful. In case of a third cranial nerve palsy, you will have to do surgical intervention. So that will be depending upon the etiology. So medical treatment will be helpful in myogenic and very few cases of neurogenic ptosis. While surgical intervention will be mainly for cosmetic purpose as well as for reducing the diplopia. And it is very frequently done in a congenital variety. And there are a lot of different type of surgical procedures. Even I am not aware of some of these procedures. There are name given here. Levator resection, I can explain that you shorten the levator palpebrae superioris. There are suspension procedure, aponeurotic strengthening, then Fasnell operation, Hayes operation, etc. So in a mild ptosis, phenylephrine test positive, you go for mullerectomy. Phenylephrine is negative, you go for fentanyl server test, and blepharoplasty levator resection. So depending upon that, you can go for different. If it is severe, you can go for frontalis sling, etc. In moderate variety, levator resection or levator advancement. These are all the different procedures. I am not aware of all those different procedures in detail. So this is Fasnell servet procedure. This is levator resection and you uplift the upper eyelid. This is frontalis brow suspension. Complication will be very frequently because of visual disturbances and later on person can even develop amblyopia. And basically because of the basic etiology, you can have complication because of the basic cause of ptosis.
Ptosis. Ptosis comes from the Greek word that means to fall. It is an abnormally low position or drooping of the upper eyelid. First, let's talk about anatomy. We are able to lift our upper eyelid up with the help of two muscles. The main one that does all the work is called LEVATOR palpabrae superioris, which attaches to the lid structures, including the lid skin causing upper lid crease through an aponeurosis, and the minor one is called MULLER muscle. Both of them work when they get signals from the brain through different nerves. Any disease affecting them would lead to ptosis or drooping of upper eyelid. Causes. These include acquired, congenital.
We already
Acquired
mentioned
include
this.
1. Neurogenic. Basically, there is an innervation defect of the muscles, and because nerves supplying the muscles are not working, the muscles will be unable to work properly. 2. Myogenic. A. Impairment of transmission of impulses from the nerve to the muscle at their junction, e.g. myasthenia gravis.
Classical example, myasthenia gravis and myopathy.
Which means pathology of the muscle itself is directly affecting the muscles involved in eyelid lifting. 3. Aponeurotic, also known as senile ptosis, in which there is age-related atrophy of the levator muscle aponeurosis. 4. Mechanical, gravitational effect of a mass pulling the lid down, for example due to a tumor.
That will be mechanical.
Ptosis could be mild, up to 2 mm drooping of
3
eyelid,
millimeter
moderate, up to 3 mm drooping of eyelid,
or
severe, 4
severe.
mm or more drooping of eyelid, depending upon the amount of ptosis present. Signs and symptoms. The most obvious sign of ptosis is a drooping eyelid. Another sign is when the upper eyelid creases do not line up evenly with each other. A child with ptosis may tip their head back,
Say this
lift
is
up their
head
chin,
tilting
or raise their eyebrows to
reduce
try to
the
see better. Over time,
reduce
these movements can cause
diplopia.
head and neck problems.
So eyebrow is lifted up
Treatment.
and even
Treatment
head is
consists
tilted
of
back
A.
and little
Surgery
towards
in
one
most
side.
cases. Conjunctival and Muller resection in mild ptosis achieves 2 to 3 millimeter elevation of eyelid. LEVATOR resection in moderate to severe ptosis,
These are the two
usually
surgical
done in
procedures.
congenital ptosis, achieves 5 millimeter elevation of eyelid. Brow suspension in very severe ptosis. B. Treat the underlying cause. For example, in ptosis due to myasthenia gravis or a
treated by
mechanical cause, treat myasthenia gravis or remove the mechanical cause.